Good evening, everyone. Hope I'm audible. Yeah. Good evening, everyone, once again for this IR webinar series conducted by ICMR in association with IISc Bengaluru. We are in session 8 today. We will be discussing on implementation strategies and process documentation. To take us through this session, we have with us Dr. Rupak Mukhopadhyay. Welcome, sir. And thank you for your time for us. And sir is the Director Research from Community Empowerment Lab. He has immense experience in the implementation research. He's published well and he has lot of field experience. So today, without any further ado, I request you now to proceed with the presentation, sir. After your presentation, we will have the Q&A session. By the time the participants will be posting their questions in the chat box or in the Q&A area. The floor is yours, sir.
Thank you, Dr. Kavita, for introducing me in such a humble and generous way, I must say. Thank you very much for the introduction and very good evening to everyone. So today, am I audible and is my screen is visible to you, Dr. Kavita?
So you're audible, but your screen is not visible yet.
Okay. Okay.
Yeah, now I can see you change the screen. Yes, now your presentation is visible. Yes, sir. Yeah.
Okay. So, thank you very much for giving me this opportunity to discuss and interact with whole lot of young and beautiful minds on implementation research. In today's session, we will be discussing on implementation strategies and process documentation in this ICMR webinar series of demystifying implementation research. Now, when we do implementation research in many ways it is different from other scientific research because in implementation research we juggle so many things together. We do so many scientific activities at the same time and all of equal importance. And it has been seen many times implementation strategies and documentation was poorly done. So today I am going to focus specially on these two key elements of implementation research. But prior to start with directly delve into these two important aspects, I would like to, I would like to invest few of my slides on reflecting on implementation research. There are many definitions of implementation research, but what is the true intent of an implementation research? Well, I have tried to, articulate it in a single sentence, which I have attempted to make less complicated for all of us. The basic intent of implementation research is to understand not only what something is working or not working, but how and why implementation is going right or wrong, and testing the approaches to improve it. So how and why and testing approaches, if we understand these three key terms, um, and we by heart these three key terms for implementation research, I think 50% of our confusion that will go away. Uh, Often we have seen that in implementation research, there is a confusion between intervention versus implementation. So I would like to take 2 minutes to, that clear that cloud. So while implementation, evidence-based intervention is practices, principle, procedures, product, drugs, or policies that has been demonstrated to improve health behavior, health outcome. On the other hand, implementation strategies are actions that needs to be taken to enhance adoption, implementation, and sustainability of evidence-based practices. So while doing implementation research continuously, we have to reflect inside that intervention is different from implementation. There will be activities we'll be doing while conducting an implementation research. Some of them are explicitly part of intervention, while others are part of delivering those interventions. That those are related to implementation strategies. Now, when we do that, uh, we have understood there is implementation research and intervention, particular evidence-based intervention. Where do they actually locate in the pipeline of doing research? And here this is one of my favorite diagram, which represent a subway line. At one part of the subway line, we have intervention or practice of interest. And on the other end, we have on different lines, we have different type of research. Very simple representation and very easy to understand, and yet it is impactful. So first question we ask, whether this intervention has shown the efficacy. If no, then we do efficacy research. And if it has shown efficacy, then we move towards the path of asking question whether it has shown effectiveness. If no, then we do effectiveness research. If it has shown partial effectiveness or effectiveness fully, then we go into hybrid implementation effectiveness research, or uh, true implementation research. That is, we try to understand the context, we try to design implementation strategy, and we test implementation strategy. Very simple, very easy to understand, and very easy to retain in our mind to understand how intervention moves efficacy from efficacy to effectiveness to implementation. So when we discuss implementation research, I have often seen that we use the term effectiveness and implementation very often very interchangeably, and which actually create confusions. So we need to the simple understanding is how implementation research is differentiated from implementation. Effectiveness research is differentiated from implementation research. Perhaps in effectiveness, if we look at it, the the, the when we look at an effectiveness research, at the background we have system to support adaptation and delivery with fidelity, a certain particular intervention. But at the forefront, we have that intervention, and we try to look at its effectiveness in terms of health outcome, while we collect the information on the system that supports the adaptation and fidelity. But the key objective is to understand how intervention is effective in terms of particular health outcome. While in implementation research, intervention take the backseat, and in the forefront we have system. We try to gather systematically the information and document the system that supports adaptation and delivery with the fidelity. So key outcome is implementation strategies and the process adapted. We often in implementation research, we get inclined towards looking at the intervention and the health outcome, but we often forget to clearly and very systematically defining the implementation strategies and the process adapted. I think this is primarily where we need to focus while we are talking about implementation research. So So I was while I was conceptualizing this presentation, I was thinking that I remember that I have started with the discussion. We juggle so many things while doing implementation research. So where to focus on? Actually, where this implementation strategies and processes, they are located within the bigger ecosystem of an implementation research where we are doing so many things. Let us look at the anatomy of implementation research. I have tried to simplify it. And it's as simple as possible. I have tried to do that. Obviously, one can include so many complexity to an implementation research. So on the left-hand side, we see an evidence-based effective intervention, which supposed to have an effective impact on a health outcome and desired health problem. So, but due to many reasons, we see there is a gap that the desired impact is not achieved as far as a particular health problem is concerned. So there is an implementation gap we see. So implementation research, what it does simply three things: assess the gap, co-design the solution, and test the solution. While testing the solution, it focuses on three primary aspects: iterative modification, concurrent outcome assessment, and the third one is process documentation. Remember, while we are doing co-designing, we identify some presumptive implementation strategies, and through iterative modification, we get the outcome of implementation research, that is contextualized implementation strategies. How we reach from presumptive implementation strategies to contextualized implementation strategies is that needs to be documented, and that is what we call process documentation. So today's discussion focuses on these two components of implementation research. I hope I able to situate them well within the ecology of and implementation, within the anatomy of implementation research, overall implementation research. So again, the same thing, but in a very simplistic format, that presumptive implementation strategies turns into contextualized implementation strategies through implementation research, through iterative changes. Documenting that adaptation is what we call process documentation in implementation research. So the precondition is we need to identify implementation strategy, we need to define them, we need to test them properly, and then we document the process, how we execute those implementation strategy. So documenting the execution of implementation strategies is what we call process documentation. What is the challenge then? If you look at across implementation research publication, you see lack of conceptual clarity. There may be clarity in defining the outcome, uh, discreetly mentioning about the implementation intervention, but you often struggle to understand how things has been done, how intervention has been delivered. There is lack of conceptual clarity to identify, develop, and test describe implementation strategies. Manifestation are primarily twofold. Number one, the terms and definition of implementation strategies are inconsistent across the literature. And the second problem is description of implementation strategies are often do not include sufficient detail, and they becomes in real world they become unreplicable. So these are two challenges. So what is the solution space? we look at, I at least I look at it from two perspectives. First, understand the nomenclature of implementation strategies, whether there is a standard systematic way to define implementation strategies, group implementation strategies. So globally, we can use them in a similar manner. When we say something that connect to a specific way of doing things, do we have such classification? And then while we when we when we put them under certain nomenclature, then it becomes very easy to document them. So that is where we say documenting implementation strategies. Well, so there there is one globally accepted way which I want to introduce to you. That is ERIC guideline of naming the implementation strategies. It's been globally used, and in one of my study, I also use this. I will take up that example to explain how implementation strategies can be identified, can be used, and can be documented. So what they have done, it's known as expert recommendation of implementing change, or ERIC. First, global experts, a number of experts, they actually uh, they they brainstormed and identified 73 different implementation strategy nomenclature that can be used across different implementation settings, and that the process can be documented. Later on in a publication, they have further clustered them conceptually into 9 clusters on the basis of and they have assessed their feasibility and their importance. I am not going into the detail, but if you can look at the diagram on the right, you can see the clusters they have made on the basis of engaging consumers, use evaluative and iterative strategies, change infrastructure, adapt and tailor the context, develop stakeholder interrelationship, utilize financial strategies, support clinicians, provide interactive assistance, and train, educate the stakeholders. Further, under these categories, we have several subcategories. If you if you I, this is one of the screenshot from the publication, and I'm sorry for this very small words, but you can see that under evaluative and iterative strategies, they have I a number of implementation strategies. For example, assess the readiness and identify the barriers of facilitators, audit and provide feedbacks, purposefully re-examine the implementation. So all these strategies are, if you look at the original publication, they are defined, and they are also, there are also examples where it needs to be used, how it needs to be used. So this is a kind of guideline which creates a, a platform where similarly, in a same way, in a same definition, we can use certain implementation strategies. Now, when we have 72 strategies clustered into 9 different clusters, then the question is that how we can select some of these strategies from this list of 72 implementation strategies, how we get to understand which strategy is suitable for my implementation research which I am going to do. Well, there are 3 methods as of now. Either you can do a stakeholder consultation using nexus planning or human-centric design to identify the strategies. There is, however, another method using framework and ERIC matching. In fact, if you are aware of the consolidated CIFAR framework, there is a tool that matches CIFAR with ERIC. They simply does four things: identifying the contextual barriers and facilitators, aligning strategies to specific barriers, use prioritization method like Delphi to rank the strategies, and then tailor the strategies to the context. Very lately, there is a publication by Powell, which actually they have identified four methods of selecting different strategies, and they use design science to do that. Number one, intervention mapping. Number two, concept mapping. Number three, group model building and conjoint analysis. So all this, I'm not going into detail, but just to give you an idea that there are methods available which will help us to select out of this 73 ERIC implementation strategies, the strategy which fit our implementation research best. So there is a strategic, a structured way of selecting implementation strategies. Well, now being said that, I will take up one example from one of my study. I was part of this study, and I will try to explain you how we have used different implementation strategies. I have used 9 implementation strategies and how we have documented that. I will give you a glimpse of documentation under each implementation strategy, and and those documentation, for those documentation I used mixed method, qualitative and quantitative method for documenting them. However, for documentation also there is framework like frame is. So frame is framework is one of the framework that helps us to identify the documentation, what needs to be documented, when needs to be documented, what has been changed. But I have not used that framework. Instead of that, I have used mixed method for documenting the process implementation strategies. So going to the example, it is a this is one of the implementation research that was conducted in rural Haryana, that is in Palwal district, and we have so we in this implementation research we attempted to strengthen the management of sick young infant in community, in primary health facilities when referral is not feasible. So what is the, let me tell you the background of this implementation research. Government of India has come out with a PSBI management guideline in 2014 and 2017 with the modification of it. And it tells four simple things. Number one, early identification of sick young infant in the community using 7 danger signs. Number two, assessment, classification, and treatment using IMNCI chart booklet in primary care facilities. Number three, manage mild illness in primary care facilities and refer serious illness promptly to the higher hospital centers after pre-referral doses. And if referral is not possible, the fourth point is that to manage those seriously sick uh, young infants in community settings, ambulatory care to the nearest OPD using simplified antibiotic regimen for 7 days. It has shown great impact in earlier efficacy trial that 7 days antibiotic regimen, the case fatality rate is very low as compared to those we are not meant, those who are not treated with with such regimen. But the problem is that although this guideline was introduced in 2014, none of the health facility, primary health facilities in rural India, they are managing sick young infant following this guideline. Although these guidelines were made initially for ANMs and then to the medical officers to primary health facilities, but I mean, there is no implementation. There is a very poor uptake of this guideline. So, our team and a team of research investigators were engaged through WHO, and a multi-center study was sanctioned in four areas of four districts in India, and I was fortunate to part of one such site. The study site was rural Palwal. It encompasses almost 2 lakhs population, 50 villages, where we have one district hospital, 3 CHC, 3 PHCs, and 18 sub-centers. The objective was simple: strengthening the health system for early community-based identification and prompt referral of sick young infant with PSBI to the nearest primary health facilities. And second is managing PSBI young infant in PHCCC when referral is refused in a safe and effective manner. So the studies team constituted of implementers were ASHA, ANM, medical officers, program managers. There are stakeholders who are beyond implementers, who are directly not responsible for implementing, but they were they influence significantly the implementation. Like we had community leadership, we have other departmental officials, training support team, and technical support unit. And then we have our study research team. In implementation research, it is also important to differentiate between implementers, study team, and stakeholder, and what each team will do. Very briefly, I'll not go into the detail. This implementation research was phased into uh, four parts: preparatory period, then we have co-preparatory period. We did all permissions and everything and formative baseline research. Co-participatory period was into a very restricted geography. We did it for 2 quarters, and we also closely observed what are the challenges of implementation. Then we had a full-scale implementation across the study site for 4 quarters, and then we had a consolidation and exit phase. So what was the result of it? Outcome. People are often interested in looking at the outcome. So let me just first talk about the outcome, and then we'll go into the further detail. If you look at, if I look at the outcome, there was a 70% coverage. Identification, most of the identification were done by the mothers, and 73% PHC and CHC treated, PSBI young infant, as compared to as compared to before implementation period, there was no treatment provided to sick young infant. They were not entertained even within the periphery of the PHC and CHC. When we looked at the adherence, we see over the time adherence increased, and the complete adherence, that is 7 injectable injections that were provided in PHC, CHC, almost to the 50% of the 50% of the and young infants, and 22% they had 2 to 7 injections, injectables, and that is the last phase of the last quarter of the implementation, full-scale implementation cycle. Now, this is the outcome, and intervention was not under the intervention. We all before even starting implementation research, we all knew the beneficial, the efficacy of this intervention, 7 days antibiotic. But what we achieved through this implementing this simplified regimen in primary health facility is that we could see there is a gradual increment of acceptance amongst the health worker as well as community of management of PSBI in a primary care facilities. So how did happen? How did it happen? What what is the story behind that? And there comes the importance of narrating the story in a systematic and structured way. Whether there is, we can take a scientific way method, we can select a scientific way and method to telling that story. So we looked into the implementation strategies, what we can right at the beginning after our initial formative research, we looked at the implementation strategies, what we can adapt and whether there is a globally available reference. We look at the ERIC strategy and we, from that basket, we selected the 9 strategies. Frankly speaking, it was done during around 2017, 18, and that time the concept of implementation research was still evolving. So the many things that we have done, we could have done it much more in a better strategic manner. But however, we were fortunate enough to do a very decent work and systematically select the strategies which can be used and can be globally understood in a similar manner. So we selected along after our co-design workshop and discussing the different challenges, we have selected these 9 strategies out of Eric's list of 72 strategies. Building coalition, centralized technical assistance, work with educational institution. Number 4, assessment for readiness and identify the barriers and facilitators. Number 5, revision of the implementation blueprint. Number 6, conduct educational outreach program. Number 7, provide local technical assistance. Number 8, development and distribution of educational material. Number 9, increase demand through structured social mobilization campaign. Now, the moment we define these strategies, it becomes so easy for us to document the how these strategies are being executed. Although there are, if you remember my earlier slides, there are many processes to document that. Like I've said, there is a process of documenting adaptation to frame is method. But we did at that time, we were not aware of that method. So we used mixed method to documenting these processes, these different strategies. How we did that? Just let me have a break and take some water. Thank you. So, so what was our experience in executing implementation strategies? We documented it using mixed method. I'm going to give you a glimpse of it so that we all understand that how the implementation strategies can be documented and how documentation look like. First strategy was building coalition. We realized and we documented that coalition had to be done at 4 different levels: at ministerial level, at state health department level, at district leadership level, and series of meeting at local governance level, that is with panchayat. And if you look at this list, at each level we have different purpose. We leveraged their influence in a in specific way and a separate way. For example, at the then time, the PSBI guideline was not harmonized with WHO PSBI guideline. So we had to have the influence and involvement interference of ministry to change these guidelines specifically for four sites where those implementation research was going on, and so on and so forth. In all level we we leverage their influence, and it is very important to document them so that later on, if somebody is going to replicate this, there is a they should be immediately recognize that building coalition is one of the key strategies that they need to use, and they have to leverage their the influence at different level for different things, different purposes. So here I have make a very concise mentioning of that, but if you go through the paper that we have published, you'll get to know what we have done at these different level, what are the changes that has been made in PSBI guideline, what was not there initially, and then what we incorporated, especially for the sites. So mentioning these processes and mentioning what has happened, what has been changed, that 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 is the key. That is the key soul of an implementation research. It is not only the outcome. Outcome is also important, but detailing these components, which becomes very essential for an implementation research. The second component, the second implementation strategy we adopted is centralized technical assistance. Now, for centralized technical assistance, we have established a technical support unit at the district with chairmanship of, chief medical officer of the district. So they have had specific role to play. While we also understood that for day-to-day matter, a nodal official will be very important. So the district appointed a nodal officer. While technical support unit performed several important tasks. They served as a link between state headquarters and district health department. They also identified implementation bottlenecks and shared with the research team what was it. This is in addition to what we identified in our formative research. They facilitate the development of implementation blueprint. They also collated field experience of district health program managers, and they reviewed the implementation progress, resolved implementation operational issues, and mid course corrections they did. So this is a very powerful group which met in every 3 months, and some key bottlenecks were resolved by this technical assistance group. So the TSU becomes very important for our implementation research. So now you can see that how we define the centralized technical assistance, and we have provided a detailed documentation how this technical support unit they operated during implementation research, what they have suggested, what course correction they did. All those things were documented under this particular implementation strategy. The third was working with educational institution. We worked with Safdarjung Hospital, who actually engaged in policy dialogue with the decision because they are one of the key influencer of decision making, health decision making, and also provided technical assistance to develop job aids for field staff necessary and messages to the community. They ratified the translation of MNCI chart booklet in local language and supported the training and capacity building activities for medical officer and health functionaries. Our fourth implementation strategy was assessment for readiness and identify barriers and facilitators. While I am mentioning the name of these implementation strategies, they are exactly same as used in, uh, on the ERIC guideline. However, we did this assessment into two parts. While in baseline situational analysis, we looked at the beginning itself, we looked at understanding the context of within the study universe. In the second part, which is co-participatory implementation, we gathered first-hand insight into the challenges and barriers of implementation guideline beyond what we obtained in part one. It has been observed that in part one, in formative research, uh, generally we conduct formative research at the beginning of the study. But we have seen that what people say, what people actually express, there is a huge difference when we are going to implement something, the way people act, the way people perform, and that is an universal phenomenon. So we in a formative phase two, we implemented some key intervention. We implemented that in restricted geography. Also, we looked at closely the pregnancy tracking, birth surveillance, and home visitations. And we did spot observation for assessment of sick infants done at the CHCs and PHCs. So I will discuss very briefly what we have observed in phase one and what we observed in phase two. That is a part of assessment of readiness and identifying barriers and facilitators. The key highlight of phase one that a considerable number of mothers could not even mention a single danger signs for their newborns. Also, we have seen when we did a quantitative assessment of ASHAs, we saw that for some danger sign they have good knowledge, but while others their knowledge was very skewed. They could not explain hypothermia, very low birth weight or low birth weight. They could not they could not explain or remember how to check for pustules and skin rashes, so on and so forth. So in detail, almost 80%, almost only 60% they had adequate knowledge of danger signs. So in formative research phase one, there were some few key take-home messages. Doctors, CHC, PHC hesitate to touch and examine sick newborns. ANMs did not consider themselves as a treatment provider. Mothers had poor skill to identify danger signs in young infants, and ASHA gave a very little emphasis on counseling mothers on danger signs. However, the stocks, supplies, they are not a problem for for health facilities as far as our research site was concerned. In uh, formative phase two, when we looked at very closely while executing while making the operational guideline, functional, we worked closely with uh, our community workers, health facilities, and community. What we saw that many ASHA missed considerable number of pregnancy in identification of considerable number of the pregnancy within expected time period. We also observed that ASHAs were hesitant to share the records of of their home visitations, citing that incompleteness. Postnatal visits, we confirmed with the family through telephonic calls that postnatal visits were irregular and not as per the schedule of Asha's. Asha did not, we have also, observed Asha's home visitations, and we saw Asha did not emphasize on danger signs to the mothers during home visitations. And Asha were reluctant to mobilize sick young infant to CHCPUC because doctors referred these infants and newborns without even assessing them. So there was a challenge of reputation of Ashas also due to all these things. While we look at the ANMs and doctors as study facility, we the problem remains what we observed in our phase one. The problems remain same. The subcenters could not be operationalized because INM did not have the confidence, and they could not consider themselves as a treatment provider. Giving immunizing the child is a different aspects, but treating a sick young infant with injectables, they fear some unpleasant outcome within the community setting. CHCPSC doctors were reluctant to assess young infants. Still, they were reluctant, and they were frequently referred them without preliminary assessment. Doctors were unwilling to use IMNCI records. Doctors were hesitant to give injectable gentamicin, and referral was almost non-functional and broken. PHCCC referred sick young infants without any referral notes, without any guidance to the mother. None received pre-referral treatment. At the community level, community had a trust issue with health facilities. They did not value Asha's home visitation because they did not know, could not recognize why, what is the benefit of the Asha's visit. They could not able to identify the danger sign timely, so there is a delay in care setting. Looking at all these things, that took us to our that took us to our fifth strategy, that is revision of implementation blueprint after a co-participatory formative research. We did this revision along with uh, along with through the brainstorming with the health department and other stakeholders. We identified three domains where we could act at that time. First domain is early identification and prompt referral to the nearby health facility. Second action domain should be the starting appropriate treatment without delay and treatment compliance. And third, across all the domains, it is creating a demand and social accountability amongst the community, and social accountability among the health service provider. Under each of these domain, we identified nudge areas. As you can see, I'll not go into detail of it. And in each of these nudge areas, we could identify 5 key nudge areas. Number one is orientation of community health workers and empowering mothers. Number two, enhance confidence in providing services to a sick young infant by health service providers. And our last three are, that is related to creating demand and social accountability. Number one, empowering mothers and families to identify sick young infant, creating awareness on scheduled home visit and expected responsibility of ASHA worker, and awareness where to get the treatment. Well, when we decided these, then it led us to the sixth implementation strategy, that is conducting educational outreach program for health service providers. We conducted workshop with doctors and staff nurse and ANMs. We also conducted workshop with ASHAs. And simultaneously, we adapted our seventh implementation strategy, that is provide local technical assistance. We focused into improving case management at CHC PHC level. Four domain we focused. First one is enhancing confidence of health service provider to manage sick young infants. So we are along with district, we planned, organized, and implemented, uh, you know, uh, mentoring visit to these health facilities by IMNCI trained supervisor, pediatrician. We strengthened the Pradhan Mantri Surakshit Matritva Abhiyan clinic for ANC and PNC counseling. And there is monthly meeting, quarterly meeting that chief medical officer used to hold in his office along with the monthly meeting. On the other hand, we created social networking platform to strengthen the referral. We were changed, we introduced a component within their referrals list at the CHC and PHC level to mention the place of referral, reason of referral, and also work with district to emphasize, to inform higher facility at the time of referral. We documented and observed how many times it has been done. Also, we another other two components of technical assistant were at the domain of strengthening HbA1c visitation and support to mobilize sick young infants to nearby facilities. We worked on, improving Asha's stake in the community. We also improve case triaging in the OPD through the OPD arrangement, making the OPD, uh, very congenial to, first give importance to the sick young infant who are visiting there for treatment. We also created, we also conducted reorientation sessions with ASHA's supervision and also local ANMs. We have observed that many of them were not able to fill the HbA1c register, HbA1c forms, ANC register properly. So we handhold them along with the district how to maintain the records properly. So that is another component of implementation strategy where we provided local technical assistance. The eighth strategy was developing and distribution of education and material. We restructured dimension recording forms, wall boards were created, and also pamphlets with key messages that were circulated, job aids for IMNC HR booklets that were created. And all these are documented. How we did that, all these were documented under under this particular implementation strategy. So if somebody wants to actually replicate those components, they will understand where we have changed, how we have changed, what challenges we have faced. So those components can be somebody we can really take through somebody through that process. Our last and most important strategy was increasing demand through community mobilization, where we focused on the three component: awareness, how to identify danger signs, and then creating awareness on HbA1c, ASHA's HbA1c visits, that is visitation schedule, and what is the expected duties of ASHA's, and our awareness on where to get the appropriate treatment. So we have tried, we did not create any parallel system within the community. We tried to utilize whatever existed, whatever existing platform were there in the community, and we try to strengthen those. So first platform where we tried to strengthen was VHND. Second, we also worked with PNC counseling at sorry uh, of Pradhan Mantri Surakshit Matritva Abhiyan program. Third, we also in all the different villages we created the wall painting mentioning clearly what was the Asha's visitation date and what they need to do. That created a real awareness in the community, and at many places community asked Asha when they could not visit on the time. So that is one of the very impactful. We although we did not measure the impact, but we documented the case studies what happened along with this particular community mobilization activity. We also engage the future mothers in creating rallies in the community. So that also found to be very effective, because when the children of the village, especially young girls, they had this rallies and mentioning the you know why a newborn newborn uh, sick newborn, taking care of sick newborn is becoming very important, where they should go, how Asha's role are important. So all those rallies created community enthusiasm to act together. We also engaged the local leaders. In the photographs, you can see the then CMO who were who was you know in many occasions he addressed the community leadership and shared with them the result of the implementation. So that becomes an encouragement point for the community, and they could understand that CHC, PHCs were getting functional. So that was also acted as a facelift of the district health system for the services they were giving for sick young infants. We could able to stitch one page of danger signs in district district immunization card, and that could be distributed across different health facilities. We also tried to gamify the this particular intervention. There was a At that time, the in Palwar district they were conducting a village competition. With all the villages were competing on the basis of certain key parameters of education and development. For the first time in this, we have incorporated the WASH parameters along with newborn care parameters. And so, since the stake is also on the ASHA worker, community health facilities, and also the panchayat, they work together in order to succeed and also top the list. So in this way we have tried to create a win-win situation for everyone. So all these strategies, 7 strategies, we could able to implement during our implementation research, and that was included in increased demands to community mobilization strategies, what we can see within the list of EDIC strategies. So I will stop at this point. What I have tried to explain with the example is how we can identify, pick, and choose some implementation strategies and how we can elaborate in a qualitative mixed methods how these implementation strategies were contextualized. Thank you very much, everyone. I will not touch upon the assessment, outcome, and so on and so forth, because that is not a part and within the scope of this presentation. I'll stop at that point. Thank you very much for the patient listening. Over to you, Dr. Kavita.
Thank you so much, sir, for the enlightening talk. So we don't have any, questions yet in the chat box. So I assume the lecture was very good. Yeah, now the questions are, coming in. Let me read those for you. Okay, so Dr. Vinay Singh has, asked about, he has actually praised about listening about this ERIC strategies. His question is how to give points or rate different defined strategies for importance and its feasibility.
Can you repeat the question? There was some
Yes.
disturbance.
Yeah. So how do you give points or rate different defined strategies for importance and feasibility? This is about the ERIC strategies that you have, spoken about.
Right. Okay. So, as I have in my presentation, perhaps I talked about this very quickly, but there are process of doing, giving comparative importance to certain strategies, following specific methodology. For example, Delphi method. So when we have certain number of strategies, we track down few strategies for our utilization, and then with a consultative method or Delphi method, we rank them on the basis of their importance, their feasibility, and then we test them in the community or in the our implementation research setting for their feasibility, and we take a decision on the basis. There is no other, you know, uh, quantitative way to verify their feasibility and applicability. So the Delphi method or consultative method is the only method to do that. Thank you.
Thanks for the clarification, Dr. Rupak. So there is a question from Dr. Srivastava. He wants to know how do we, assure the efficiency of the implementation strategies.
The only way of look at the efficiency of the implementation strategy is through doing a pilot. So those are the iterative tests needs to be done, looking at the what is the expected outcome. We clearly define the expected outcome. We document them systematically, and then take a decision on that efficiency of that implementation strategy.
Yeah, thank you. And Dr. Venu wants to know for a beginner in IR to suggest some implementation strategies to enhance basic understanding. So, yeah, the question is a bit confusing for me, but what I understand is how to start. Okay, as a beginner, maybe Dr. Venu wants to know what is the starting point? What is the starting point to learn the implementation strategies? Maybe that's the right thing, or maybe Dr. Venu wants to write what exactly he wants to know.
Read the question once again. Just don't
Yeah.
interpret it. Just read it out.
Okay, okay. Yeah, so for a beginner in IR, please suggest some implementation strategies to enhance basic understanding.
Okay. So what I would suggest, instead of giving an reactive answer, I would suggest Dr. Renu to look at all 1772 ERIC implementation strategies. With along with the name, they are defined quite well. So just have a look And there is no if you look at all these strategies, there is nothing like that one is easy for beginner and another is difficult for the beginner. No, it's not like that. It is on the it is defined on the basis of implementation need. So along with, if your implementation need, for example, suits a strategy of, for example, a technical assistance, provide local technical assistance, then you have to see what you will be doing under providing local technical assistance. That all those components needs to be defined. We can go another further one step, define when it is to be given, what is the dose, and how it is the result will be measured. So I have told you that earlier, because since we did our study in 2017 and 18, the field has evolved after that period. So now, even doing an implementation, executing an implementation strategy, also there are publication that says that you can define the implementation strategy, define it dosage, measure it. So those components can be added over the time. But I would say, right for the beginner, that you start with a very simple qualitative or mixed method understanding and description of implementation strategy. Thank you.
Yeah. Thank you, sir. There is a question from Dr. Jyoti Singh. She wants to know whether the implementation studies has to be registered in CTRI.
uh, if you are doing an implementation research that involves hybrid methods, for example, for one part you are looking at the effectiveness of it and doing a cluster randomized trial as a part of implementation research, for that part it will be requiring a CTRI registration. At least we did that for one of our study. Otherwise, for an implementation research, whole and so purest implementation research, it doesn't require.
Okay. Thank you, sir. So there is a question from Dr. Karthikeyan. He wants to know what is the difference between implementation strategies and implementation research.
Okay, Dr. Karthikeya, I would only say that implementation research, if you look at the simplified diagram, it includes understanding the context, you know, developing the solutions, and then testing the solution. It includes many things. Implementation strategy is only one part of it. Like we try to understand how we have an intervention or a bundle of intervention. We try to decide upon how we want to deliver those interventions. So there comes the domain of implementation strategies. It is not so. If you say, if you ask me, implementation research is a house. Only one component, one room in that house is implementation strategies.
Thanks for the clarification, Dr. Rupak. And Dr. Desai wants you to share more about documenting ongoing adaptation optimization of strategies during the course of study beyond pilot area. Also, please guide about documenting WHO implementing strategies.
Okay, so right now I am not aware of what he is mentioning about WHO documenting implementation strategies. There is a guideline that is providing by TDR, where they have talked about the qualitative methods of documenting implementation strategies. Uh, uh, but what I have discussed, the guideline of implementation strategy, I have mentioned briefly about FRAMEIS, FRAMEIS. If you Google that, you will get a whole lot of write up on how to document the adaptation. That is another way of looking at how we can document implementation strategies. Since I have not used that, I have only briefly mentioned that, but I could not give that example. I can share the publication with you. Thank you.
Yeah. Yeah, that would be great. So there's other question about the ERIC, strategies. Is there any process of choosing the strategies from the ERIC list, or is it completely based on what the study or the project demands?
No, there are published, as I have said, that there are published method of looking at the ERIC strategies, right? So there are intervention mapping, conceptual mapping methods. There is also one tool which actually published, which actually the publication says there is a way of locate how CIFER and ERIC, from CIFER you identify the barriers, and there is a systematic process tool that actually map CIFER barriers with an ERIC implementation strategy. So there is a way to do that.
Yeah, thank you. There is other question. Sir, can you please repeat the example you gave and give little more clarity on which type of intervention need to be registered? This is about the CTRI registration. It's a
So
follow-up
im-
question.
implementation research, if it is an purist implementation research, you need not to go for an CTRI registration, number one. But there is another type of implementation research which falls under the category of hybrid implementation research, where we do implementation research, but as well as we look at the intervention using stepwise trial or randomized controlled trial. If any stepwise trial design or randomized control trial design is part of your evaluation within the implementation research, then you have to take CTRI permission particularly for that part. I hope it is clear now.
Yeah, hope it's clear now for Dr. Jyoti. Yeah, she has written yes, thank you. So there are no further questions. If you want to add anything else, Dr. Rupak, that would be great before we, close the session for today.
I would like to, uh, convey my regards to, and also heartfelt thanks to ICMR, as well as uh, continuous encouragement by Dr. Vishwajit Kumar. I look up to him for many, intellectual inputs to whatever I do. Also to, you know, people of Haryana, Palwal, and since this study I did while I were working under the guidance of Dr. N.K. Arora and in Klein, I'd like to convey my regards to them also, and also to the great audience who patiently listened to me. Thank you very much.
Thank you so much, sir. It was a great session and great discussion. And we are looking forward to have you more on such webinars. That is what we are, receiving messages from our participants now. Thank you so much. So the next session we will have on December 4th. We will have Dr. Premoni to deliver the session on implementation research outcomes and evaluation method and designs. So the timing will be the same. Date is on 4th December. So we all look forward to meet you again and all the participants to join us again for the next session. Thank you so much till we meet next time. Thank you once again, sir, for sparing your valuable time with us and delivering such an enlightening talk and clarifying all the queries of the participants. Thank you so much. Thank you all the participants. Bye till
Thank
we see next time. Thank you, sir.